So I think we can start with the second part. So anyway, we would like to welcome everyone again to the second part of the first ELSA outreach program webinar series for 2021. So this is a certifying course. This is the second part of a three-part series. We have to remind all our residents and our fellows who would want to have their certificate. Please log in with your name, and then you need to finish part 3 of the three-part series for you to be able to get the certificate. Anyway, I'll be co-chairing this program, this part 2 with Sujit, but right now Sujit is indisposed of because he's still in the OR. So I'll be co-chairing this with a very good friend of mine, Sajid from Pakistan.
Thank you.
So to introduce the program, we'll start off with different surgeries. This is the part 2 now. We've invited several experts from the Asia Pacific area, from Singapore, Nepal, Malaysia, Vietnam, Pakistan. So to start off, let me call on Sajid to introduce the whole course. Sajid?
Yes, Prof. Thank you, Prof, for a brief introduction of this ELSA OP webinar series. So what we have until now is we have conducted very successfully the first part of this part 1 of this ELSA OP basic laparoscopic course. Next slide, please. Yeah, so this was our first part 1 of this hybrid basic laparoscopic course, which we conducted very successfully. And today is the second part of this hybrid basic laparoscope skills course. Let me go through the one by one. The next one, please. So here are the stats for the first part of this laparoscopic course. 46 countries were involved, and there were 444 participants from these countries. These are the stats which are available. 234 were the unique viewers. You can have a look onto the viewership on the YouTube as well. 185 were the concurrent viewers. 73% of the out of these 444 registered was the attendance state. And in the end, there was a question and answer, and 129 responded to the polls. So here you can have a look. The maximum number of participants were from the Philippines. We have individualized the countries from the whole Asia Pacific region, followed by equal number from the Malaysia and the Myanmar, and then from the Pakistan and United States as well. So here you can have a look the broad spectrum of the this ELSA organization. It is not only into the Asia Pacific, but here you can have a look into the Bolivia, France, one person from the France, Far East, like in Egypt, as well as from Ukraine and Uzbekistan, Yemen. So you can have a look into the, the involvement of the participants across the world. So 153 were the respondents, and 132 completed all MCQs. 83% passed with a positive rate of 75%, which was a passing rate for the these question sessions. So today we are going to hold this part 2 of the video master class under chairmanship of Professor Alan Bunafe from Philippines. We are looking forward Dr. Sujit, and he would be joining us very soon. Let's start with the first. The today program is to go with the ergonomics in MIS. It is actually a video master classes, so we will go step by step through all the videos of ergonomics, basically, then diagnostic laparoscopic, and then the other basic procedures like appendectomy, cholecystectomy, inguinal, and the ventral hernia repair. And by the end, we will conduct again an MCQ session followed by certification. So we can start with the, sorry, the next one, please. This one, the part 3, this is very important, because the first 2 sessions which we have conducted so far, including today, is the online session. But the third session would be hands-on training, and we have planned to do it like in a hybrid way. The part of this is a self-learning module. The candidate needs to attend a hands-on session at one of the ELSA training facilities in the country, which is recommended by the ELSA organization. So either it can be done in the 2 ways, either through the facility of the country, or record a video of performing at least 3 laparoscopic surgical skill tasks, for example, peg transfer, sugar cube stacks, like all these procedure. In the video, the candidate must be recognized, and video need to be uploaded and sent to ELSA Secretariat via email. You can upload via Dropbox or WeTransfer or similar cloud hard drive by April 15. Remember the date, by April 15, 2021. We will share the details later as well on our through our app, and all the details can be found on to the ELSA website as well. Okay, so let's, yeah, please.
Yeah, thank you, Sajid. I think the most important part of the certification program is the third part. After every part, actually, of part 1 and part 2, we have an exit exams. So please do answer the exit exams. And with exit exam, please identify yourself. We can only give the certificate to those candidates, obviously, that are identifiable. Anyway, as what Sajid have said, the most important part again would be the video, or you can actually go to the Center of Excellence that's accredited by ELSA in your own country, like for example, in UH in Singapore, or in TUNS National University in Vietnam, in Ho Chi Minh, or in Philippine Center of Advanced Surgery in Manila, Philippines. Anyway, if you don't have any access to any centers, you can actually do the program by yourself with a video recording, but you need to be identified in that video. Your face should be seen that you're the one who's doing the procedure. Anyway, what we've done in our country, we partnered with the local society like Southern Tagalog chapter of PALES or PCS. Then we'll come up with our own program just so that the participants can be certified. So these are the things that we need to do for us to get our certification. And mind you, the certificate will be coming from ELSA. So it's a very nice program. The certificate will be coming straight from ELSA. Anyway, without much further ado, we would like to welcome everyone once again. We would like to thank first and foremost David Lomanto, Professor Lomanto, for coming up with this program, and of course the board of directors of ELSA. Without the board, and of course our president from Thailand, Sutepodon Salingsuk, who's the president of ELSA. So anyway, we would like also to thank all our lecturers, our expert faculties for today. Sajid from Pakistan, Tun from Vietnam, Ong Min Tu from Singapore, who else? Tuhin from Nepal. Did I forget anyone? Gafur also from Malaysia. Yes, of course, a very good friend of ours. Anyway, let's start off with the first lecture. This is a video session. So we'll start off with ergonomics lecture and video coming from Ong Min Tu from Singapore. Ong, thank you. Let's start sharing. Let's start sharing the lecture of Ong. Yeah, for all the participants, if you have any questions, please type it in the Q&A box, and we'll try to answer all the questions every after lecture or videos. Thank you. We would like to acknowledge Sujit Wijaratne from NUH Singapore, our co-chair. Sujit. Hi, Sujit. Sujit, would you want to say something while waiting for the slides of Augmentu? Sujit?
Sorry, boss. I am a bit in a rush. I just scrub out, so I don't. My slides are not ready. Yeah, is anybody can start? Sorry, I just finished operating.
No, no worry. You just a
Don't
welcome.
worry. Just a welcome address from you, Sujit.
Yeah.
Just a few words to welcome everyone.
Aung,
this afternoon.
Aung, you have any problem? Aung?
I'm not sure, Prof. I think it looks like the internet is a bit unstable. I think. Can you hear me?
Yeah, can hear you.
We can hear you all.
Okay, then I will start sharing the slides.
Go ahead. Ah, yes, your image was frozen.
Can you still
Prof,
all hear me?
Yes, you can hear you. Go ahead.
Can you see my slides?
They're coming.
Yes.
They're coming.
Coming up.
It's coming up all.
Not yet.
Can you see my slides?
Relax.
Yes.
We can see it now. Thank you all.
Can you still see my slides?
Yes, we can see your slide now all.
How about now? Still cannot see, is it?
We can see your slide now.
Okay,
It's visible now.
The
It's visible.
connectivity
We can see.
Okay, connectivity is a big issue, I think, yeah. So first of all, I would like to thank Prof. David Lamento, Dr. Ellen, and then the rest of the team at the organizing committee for the kind invitations. So today my talk is about more on the ergonomics in the laparoscopic surgery. So we are part of the ELSA, the communication, and then the program. So ELSA outreach is the part of the ELSA organization's initiatives to start. So there's no conflict of interest. So we all know that an MIS trend has been more and more popular, as well as the advanced minimally access surgery has been applied to many more complex and complicated surgical procedures nowadays, including the esophagotomy, Whipple procedures. So from the eye data research on the number of cases for laparoscopic procedures are performed, almost over 30 million of the laparoscopic procedures were performed globally every year. So you can see the volume of the laparoscopic procedures nowadays. So that was the published in Surgical Endoscopy in 2013 about the overview of the MIS adoption rates and volume growth. So you can see that we can see the growth rate of about 1% to 9% to up to 20 to 30% over the year. And then you can see that most of the procedures are now doing as a laparoscopic procedures or minimally invasive procedures. So the problem with the challenges in the laparoscopic surgery is mainly the mechanical restriction or visual limitations. So mechanical restriction means that there is a limited number of the degrees of freedom and diminish the thigh feedback. Also due to the small and long endoscopic instruments. So these are also causing the issues in the constraints in the endoscopic surgery. And then also the problem of the tissue retrieval and fulcrum effect, as you know that the laparoscopic the instruments are going through the ports, and the fulcrum effect will also have some restriction mechanically. And then some of the visual limitations, such as the loss of the normal binocular vision, which can be corrected by the 3D laparoscopic approach. Also, some of the monitor location causing the decoupling of the motor and sensory spaces. And then the lens system and light fibers cohesion alignment are the potential issues which can cause the challenges in the laparoscopic surgeries. So you can see that compared to the open surgery, laparoscopic surgery is ergonomic ceiling is the physical and mental result will be reduced in the laparoscopic surgery. Means that there's a lot of stress to the operating surgeons. So that's why surgeon will feel very tired or so-called fatigue after the laparoscopic surgery compared to the open surgeries. So this is the evidence showing that compared to the open surgery, laparoscopy or MIS surgery has a more musculoskeletal pain compared to the robotic and open. So you can see that laparoscopy or MIS surgery has a lot of musculoskeletal strain to the surgeons. So what is ergonomics? Ergonomics is actually the applied science to deal with in terms of the human engineer or human factors engineering between the human as well as the environment to have to design things to make sure that the operators or human factors are having the best outcomes in terms of doing the tasks. So you look at it, the ergonomic MIS is important because the most significant challenge in the MIS surgery is the recognition of the spatial separation of the aspects of the vision as well as the aspects of the physical aspect of the procedures. And we have already shown that there are higher rates of error in the procedures as performance decreases, as I mentioned earlier, by working in a separate coordinate system, as in the case of the minimally invasive surgery. And so the goal of the ergonomics in the surgery is to enhance the effectiveness and efficiency in the man-machine interactions, to reduce the surgeon discomfort and fatigue, which might lead to the surgical errors. So in terms of that, by reducing the surgeon discomfort, fatigue, and errors, it will ultimately increase the patient safety. So that's why Prof. Lomanto thinks that the ergonomic is in minimally invasive surgery is one of the important topics for this course. So what are the ideas for the ergonomics in the MIS? So we know that during the laparoscopic surgery, ability to achieve this ID posture is very important, which can be determined by the height of the operating table, the position of the visual display, which is the monitor in minimally invasive surgery. Also the foot pedal locations, make sure that it is quite nearest to the surgeon's foot so that it will not have a strain on the body. And also the selection of the instruments, which is the appropriate to do the comfortable surgery. So these are ergonomics, the ID ergonomics as described in the literature, so that you can see that eyesight should be about 3 to 4 feet away from the surgeons, and then about 10 to 20 degrees lower down, so that it will have a good, not much strain on the patient surgeon's neck or shoulder. And then the hand should be about 90 to 120 degrees with the elbow flexing towards the body. And then also the height of the table also is important to perform the surgery comfortably without any fatigues to the patient surgeons. So you can see that this is another cartoon showing the key elements of the ergonomic laparoscopic surgeons. As I mentioned, the pedal should be at the same level and near foot so that at least easily reachable by the surgeons. Instrument and handle at the elbow height to make sure that it is very comfortable. So you need to know how long is the instruments and also how long is the length of the instruments. Because in the bariatric surgery, we use a longer lens, and then the normal laparoscopy, we use a slightly shorter lens. So we need to know your length of the instrument as well. And then to make sure that visual angle to monitor is in a comfortable position as well. So this is another cartoon showing the optimal body positions. Your arm should be adapted so that it will not have like a chicken wing open arm. Otherwise, it will have a lot of the shoulder pain after the prolonged laparoscopic surgeries. So this is an optimal position. So surgeon should be as comfortable as possible when performing the surgeries to reduce the tiredness and fatigue during the surgery. So this is the position of the monitor, which should be along the eye sides. The other thing we need to know is the optimal ergonomy is the angles of the instruments. Namely, is the manipulation angles as described in the cartoon, an azimuth angle and an elevation angle, which is from the horizontal plane or from the optical camera system. So these are the angles which will also define the range of the motions. So that's why it's very important for us to know these angles and how during the laparoscopic procedures. You can see that the optical axis, if you use a 30-degree scope, you will see the 30-degree scope is showing the 30-degree optical axis compared to the actual physical axis. So there is some constraints to the operators, the hand-eye coordination as well. The other thing we need to know is in the laparoscopic instrument is a fulcrum effect, because laparoscopic instrument, long instrument, are introducing through the ports. That's why there is a movement will be either tangential movement or radial movement. We need to know this line of the movement or this line of forces to make sure that you understand these line of forces when you are operating laparoscopically. So the principle for optimal ports are defined by the triangulations to the target organs, and then the degree of freedom of movements and manipulation during the procedure itself, optimize visualizations. And also the most important part is that you need to put the ports according to the internal anatomy rather than the surface, the body habitus outside the torso. You need to think of the length and width of the torso and abdominal wall thickness, etc. And as well as the type of the surgery, which is the target organ, to define where will be the best to put the ports. So these are the basic principles that is described in literature. It's the diamond concept of the port positions, where is the target organ, the home camera, and then a working port on the first and third will be to having this diamond effect. And you can see in the right side, the port position in thoracic surgery is that you get the optical camera will be in the middle, and then the two ports will be the one side of each to give you the diamond or triangulation effect. So look at this is the obese patients. Then how where should I put the obese the ports, especially in the bariatric surgery? Because obese patients have a very thick abdominal wall, so we need to find how can we put the ports ergonomically to make sure that it will not much tilting effect to the surgeons. Otherwise, will be a very limited degree of freedom movement in the laparoscopic surgery. So these are the port positions. You find out that where is the area of the surgery. So because of the bariatric surgery, we are working on the stomach. That's why bariatric surgery patients are usually put slightly higher up to get the best ergonomic effect to reduce the surgeon's fatigueness as well as the tiredness after the procedures. So this is another picture showing the ergonomic placement of the ports to make sure that you will perform the surgery without much of the tiredness. Okay, so this is a thoracoscopic procedures. In the thoracoscopic procedure, is more difficult because of the rigid thoracic cavity. In that case, sometimes you might need to hold the instruments in a different way to make your hand-eyes coordination as well as your wrist joint as well as elbows to be more in the comfortable manner to achieve the same task. So this is a 3D laparoscopic, so that you can see that I'm looking down to the TV system, which is and then also I'm very comfortable with the arms adapted to the body so that I can do the prolonged procedures without much of the fatigue if you follow the principle of the ergonomics in a minimally invasive surgery. So this is another one. I'm sitting down and then performing so this one you can see that I'm looking up, means that the visual is I'm extending the neck. I will have a lot of pain after the procedure. You can see my assistant also looking up so that it will not in the very good ergonomic position. So that these are something we can improve how to make it as a more ergonomic by putting the monitor down to the eye levels, as I mentioned earlier in the slides. So in that case, then I will move to the single incision. With the single incision or single port, we may not able to achieve to the extent of what we wanted because all the ports are close to each other, and then much of the fighting each other. So in that case, we need to find out how will be the best ergonomics to minimize the tiredness or fatigueness to the surgeon as well. So you can see that this is the pictures of the single site surgery. You see the ports are close to each other, so not much of the triangulations, and then only the in and out movement of the instruments, not much of the triangulation effect. The azimuth angle or no elevation angles, all these things are not able to achieve in the minimally single incision minimally invasive approach. So in that case, we need to find out how will be the best position to how to rotate the body, how to make sure that we can achieve the best ergonomics in these challenging minimally approach in a single incision approach. So this is the clasp port. I usually like to use the clasp ports because we can clasp port have a more maneuver because inside fascia is about 2.5 to 3 cm width in the fascial defect so that we have more fulcrum, we have a more freedom of movement to maneuver. We can have a bit of a triangulation. That's why I personally prefer the cleft port approach compared to the other type of ports. So in summary, understanding of the ergonomy is very important for a safe and efficient minimally invasive laparoscopic surgery. Applying the knowledge of the ergonomics can not only reduce the stress and level-related injuries to the surgeons and assistant, but also to prevent the intraoperative complication, which ultimately will lead to the improved patient outcomes. So the other thing I'd like to highlight is that ports should be placed according to the internal anatomy, body habitus, and types of surgery rather than the surface landmarks to achieve the best ergonomic outcomes. Thank you very much. I will stop sharing.
Okay.
Thank you.
So I think, yeah. Okay, Sajid, you carry.
Yeah, okay. Thank you, Ong, for a very beautiful presentation on the ergonomics in MIS. Let's move on to the next presentation by Tohin Shah. He's clinical fellow with Professor Lumanto. Currently, actually, he's from Nepal and working with Professor Lumanto in minimally invasive surgery in Singapore. So, Tohin, over to you for a diagnostic laparoscopy.
Thank you, Sajid. Thank you, everyone, for this opportunity. So, okay, I'll share my screen.
Yes, please go ahead.
Okay, I hope my screen is visible.
Yes, visible. Please go ahead.
Okay, so I'll be speaking on diagnostic laparoscopy. So, diagnostic laparoscopy. So, the use of minimal invasive surgery for the diagnosis of intra-abdominal diseases. So, we use this approach. So, diagnostic laparoscopy facilitates the diagnosis of the intra-abdominal diseases, and it also makes the therapeutic intervention possible. So, it's more beneficial in that aspect. Also, with the in diagnostic laparoscopic, I think the biggest disadvantage is the loss of tactile sensation. But with the advent of laparoscopic ultrasound, this gives us the additional advantage with the diagnosis and also for the therapeutic methods. Also, with the use of diagnostic laparoscopy, there is a possibility for conversion or the lap-assisted approach to aid with the therapeutic interventions in diagnostic laparoscopy. So there are various uses for diagnostic laparoscopy. They can be used for staging of cancers. They can be used for diagnostic laparoscopy for acute conditions, diagnostic laparoscopy for chronic conditions, and for other uses like for general reviews in patients, for diagnosis of complications and treatments, and others. So diagnostic laparoscopy, these are the certain principles that we can follow, or the certain things that we can keep in mind when we are doing it, which will help us not only for the diagnosis, but also for the treatment, and for ergonomically, it will be helpful. So for the positioning of the patient, we can start with the patient in supine position with, of course, under general anesthesia. Depending on the pathology and the treatment that is to be required, the head up or the head down position can be sought. Also, the lateral tilt position can be will depend depending on where the pathology is. Access has to be careful because in certain conditions, they can be the intestines and other organs can be really close, so it can be difficult to get a proper access to the peritoneal cavity. We can use either Verey's or the open Hassan's technique depending on the comfort level of the surgeon. For the instrumentation, it is advised and preferred to use atraumatic graspers to prevent the injury to the bowel as well as the other visceras. And also we should avoid excessive use of cautery to avoid inadvertent injury to other surrounding structures. So we should start with the initial inspection of the peritoneal cavity. This can start either from the relevant structures where the pathology lies and then include the rest of the peritoneal cavity, or vice versa, depending on the surgeon's preference. Also, we can take biopsies while doing the diagnostic laparoscopy, which is an added advantage. we should look for signs of inflammation in the peritoneal cavity. For example, if there's any swelling, any erythema, fibrinous exudates, inflammatory adhesions, or formation of phlegm. So all of this will also help in the diagnosis, and also for the will point towards the diagnosis and also help for the treatment aspect of it. Also, we should look for the nature of the ascitic fluid that is present in the abdomen, whether it's clear, whether it's purulent, it's bilious or feculent. This will help not only for the diagnosis, but also will tell us about the extent of the treatment and how we should proceed for it. Now, placement of ports is very important, like Ong just described. So we should be able to place the ports in maybe in a semicircular position and or pointed towards the pathology, depending on like after we do the initial inspection of the peritoneal cavity. Now, just describing few of the patients. So the first patient is a 56-year-old male who presented with features of intestinal obstruction for 3 days. So this patient had undergone a previous laparotomy many years ago. So if you look at this X-ray here, we can see jejunal dilatation. And on the CT scan, we can see ascitic fluid in the abdomen with this area of pathology, which shows the kinking of the jejunum. So the plan was to start with a diagnostic laparoscopy. So once we enter, we can see the ascitic fluid, which is cleared, aspirated. And we can see there's the bowel is dilated. So we have to be careful while putting in the ports and with the instruments. Now we can see that's the pathology. That is the area of adhesion. So we should be careful with the use of instruments. So we try to avoid the use of heavy graspers or traumatic graspers. And we should try to avoid the uses of excessive cautery. So we are using scissors to release all these adhesions. So here now we have released the kink, and now after releasing this adhesion, we should look for any inspect the area of adhesion just to make sure there is no injury to the bowel. Then we'll proceed with the inspection of the rest of the intestine. And then we do a thorough peritoneal lavage and place drains in the peritoneal cavity. Okay, now coming to the second case. This is a 24-year-old male with Meckel's diverticulitis. So again, we start from the IC junction and we inspect the bowel proximally, and we should be careful about the instruments that we use, and it should be done systematically. So here we can see that's the Meckel diverticulum. So here we can also see these adhesions towards the mesenteric side, which needs to be released. Again, we should be careful with the use of cautery. There you can see the adhesions there. So now after having released these adhesions, then we can proceed with the resection and anastomosis to remove the Meckel's diverticulum. Okay, now coming to the third case. This was a 36-year-old female with feature peritonitis and free gas under the diaphragm as seen in this X-ray. So we did a diagnostic laparoscopy for this patient. So once we enter the peritoneal cavity, we can see the inflammatory, the fibrinous exudates and the inflammatory exudates that is seen along with the ascites. So as we can see, it is bilious ascites. So we know this will help in the diagnosis. So we look for the duodenal ulcer. So we release these adhesions, inflammatory adhesions, and then you can see that's the duodenal ulcer. So we start off by general inspection of the end of the peritoneal cavity, as well as we remove the bilious ascites. Also, this helps in the general inspection of the intestinal cavity, of the peritoneal cavity, and to make sure there is no other pathology or adhesions. Okay, now coming to the ulcer, we first refresh the margins. If required, we can also send in biopsies depending on the surgeon's preference and what we see intra-abdominally. Okay, now we do the omental gram patch or omental patch repair. So stage switches are placed on either side of the ulcer, and first the primary repair is done. So we also need to know the laparoscopic suturing skills should be, the surgeon should be able to have good laparoscopic suturing skills. This is going to help a lot during the laparoscopic procedures. Next, we proceed with the omental patch. This is now fixed using a vicryl suture. After this, we just clear a good parental lavage is done, and followed by placements of the drains. So I think the laparoscopic skills are important. The suturing skills, the other instrumentation ergonomics are important while performing diagnosis, not just diagnostic lab, but all laparoscopic surgeries, and the importance of all of these. Thank you so much. Okay, I'll stop sharing my video.
Yeah, thank you. Thank you, Tohin, for a wonderful presentation on the diagnostic laparoscopy.
Thank you,
You
Sajid.
can stop sharing. You can stop sharing. And we will move on to the next presentation. A good friend of us, Mr. Ghafoor Mubarak from Malaysia, on laparoscopic appendectomy.
Hi. Thank you, Sajid. Thank you, Elsa, Prof. David, and Alan, and the rest of the gang. So I've been given 10 minutes to talk about laparoscopic appendectomy. Now, it sounds like a very simple topic, but it is, oh, I think someone has to stop sharing first.
Yeah, Tohin, can you please stop sharing, and then Ghafoor would be able to share his screen.
Right. So laparoscopic appendicectomy is actually, I mean, it's something that many of us do and many of us let our residents do. In fact, it's one of the easier procedures to teach. However, we have to understand that when it is such a straightforward procedure, the expectations of patient also becomes, how do I say, different, because they feel that it is an in and out procedure and there shouldn't be any problems. So those who have done this, I mean, those who have been doing surgery long enough realize that we always come into problems not with the big cases usually. We normally come when we have a very simple case, for example, a hernia or an appendix. And this is the one that actually creates more stress when we go into problems related to those cases. So it's very important to have a very systematic way of doing it, so that in the end, you know that in 99 or almost 100% of cases, the outcome is expected because you follow a specific system. So let me just put up my slide. You can see my screen, right, Sajid?
Yeah, yeah,
Okay, let's go straight into it. I've got 10 minutes. So patient preparation. So now you've decided that you have a patient that has got appendicitis and you want to proceed for a laparoscopic appendicectomy. So the only contraindications I feel that will preclude you from doing it laparoscopically is if the patient has got advanced pregnancy. And for those who are viewing, I believe that many of you are training to become surgeons, then you would not perform it laparoscopically if there is gross peritonitis in this patient, because you would require a quick in and out procedure. But if you have attained enough skills in performing other laparoscopic procedures, or you have done enough laparoscopic appendicectomies, in fact, it is an advantage to do it laparoscopically because you can do targeted wash and your lavage is more systematic and targeted to specific areas, and the outcome is better for the patient. So I would still say advanced pregnancy would be the only contraindication that I would feel would preclude you from doing a laparoscopic appendicectomy. Now, what if patient already has a midline scar for something else, and the patient comes with the right-sided abdominal pain and you need to do a laparoscopic appendicectomy? I feel that laparoscopy is good in this situation as long as you can get the first trocar in, clear the adhesions around the areas that will preclude your vision to the appendix, and do it. This would be an ideal situation. Intravenous antibiotics, depending on which country you're from, I'm sure everyone has got their own regimes. And in Malaysia, we rudimentary give prophylactic antibiotics for patients undergoing appendicectomy. Catheterization, I don't think is needed. Normally, I'll ask patient to pass urine before they go for surgery. So I don't feel that if you're doing a laparoscopic appendicectomy, it is required because it is normally a short procedure. Consent is very important. And consent is important in this aspect because you must tell the patient that you might have to convert your procedure to open. Now, I can't remember when is the last time I converted laparoscopic to open. However, I have appeared for many surgeons who have some medical legal issues, and expert witness is required. And in that process, the patient says that he was not told that the procedure has to be converted to open if there is a problem. So consent in this element, though it is just an appendicectomy, you have to inform the patient that if you have any problems during the procedure, you'll proceed to open. Position is very simple, supine with arms tucked in. You can have the patient extend the left side of his arm out because anesthetists love having their hands out so that they can deliver drips easily. But normally, if hands are tucked in, it is much better. Basic instruments. Now, it might differ from place to place, but I feel that these are the basic ones that you need for a laparoscopic appendicectomy. Atraumatic bowel grasper, a good one, the one that can hold the bowel. A Maryland attached to a bipolar diatomy or a hook diatomy is ideal. If you have both, is good. If you have either one, is good. endo pouch or tie. You can tie in, if you're skilled enough, you can actually perform the tie on the base of the appendix and also on the appendicular artery on your own if you need to. Flush and sucker tubing for wash. Now, if you have the amenities and you have the availability in your center to go a bit better, then an energy device, especially when you're dealing with cases that have got adhesion or cases that have got a lot of contamination, an energy device, either a harmonic or a sonicization or any energy device would be ideal. And most likely you will need an additional bowel grasper to run the bowel, most likely to look for other pathologies, namely a Macus diverticulum. Now, when you have now we've already decided to go for surgery, we have the patient on table, and also we want to decide for port placement. So these are the general placements. Normally you put a 10 mm port at the umbilicus. The most common that I've seen so far is a 5 mm at the right iliac fossa and a 5 mm at the suprapubic region. The problem with this placement is the port at the right iliac fossa tends to be very near the appendix. And so you have to elevate your left hand when you're doing it, which is not ergonomically good for you. And it gets you, it will shorten your laparoscopic career very significantly. So the other alteration to this triangle is to put the 5 mm third trocar in the left iliac fossa. But if you do that, the distance between where you're inserting to the appendix is very far away. So that is a problem with that. Alternatively, you can do the third, which many people call the bikini or the underwear scarf or appendix, where you put a 10 mm port at the umbilicus and 5 mm below the inguinal ligament on both sides. I find that this is very good, but it causes a bit more pain as compared to the other two. Of course, you have got other variations where all the ports are lined up from the umbilicus to the suprapubic region, all three, and you also have got uniport technique, or you also have got 2-port technique using a needle to poke the appendix as a retractor. But all these are just variations, and whichever works with you should be okay in general. But get comfortable with one technique before you move on to the others. So let me just share the video that I have. First, I stop sharing this first, and then let me share again. Yeah, okay. So this is an interesting video because this was initially done by me because it is a staff's mother, and I was asked to perform the operation. But in between the operation, I was asked to help another friend in another OT. So my resident took over in the middle of the operation. So you can see that there are some things done right and there are some things not done right here. And I think it's a good teaching video for all of us. So when I start, I use a bipolar forceps routinely, and I try to release as much adhesions as I can. You can see the appendix already from this, but it is stuck and it is hiding under the cecum. So immediately I know that it is difficult to perform this procedure. So what I do is with the bipolar, I use an energy device. And in this case, I use a harmonic, all right? So what I do is I release the adhesion in the side, and the trick is here to find any part of the appendix that you can get on your grasper. And normally it depends on operation to operation. So in this case, the part that I can get on the grasper is the base as compared to the tip. So you have to work with what you have. And a lot of adhesions are preventing the appendix to actually appear because it is stuck below the cecum, all right? So just moving on, beyond that, at about here. Okay, so when I come here, I get a bit more base and I move more and more towards the body of the appendix and more to the tip that is actually, I think, the problem. So in this case now, after dissection, I should be able to, there, I can find the tip already. So in appendix for laparoscopy, you don't necessarily have to find the whole structure first to do your dissection. You work with what you have, and then you work either towards the tip or towards the base from actually where you have started. So in this case, I began at the base, but I worked my way up, right? So after this, it's quite easy. If you have an energy device, or even if you don't, the idea is actually to get the whole appendix free from the base, and then subsequently get as much clearance as you can from the base. This is very important because you are going to apply a tie at the base. So it's very important that actually you clear all the strands of fibers as much as you can from it. Because I find that when I go in for post-appendicectomy syndrome, I find that the stump has got a lot of adhesion strands which haven't been released during the first surgery. So once you have released, so in this case, I know that there's difficulty releasing with the harmonic. So I change my instrument back to the bipolar forceps to actually release the adhesive bands so that it will make it easier for me to apply the ties. Okay. Right, this is this. Okay, then once you've cleared enough, you can either tie it on your own, but in this case, I felt a bit luxurious, so I used an endo tie, and subsequently you can transfix the base. You can detach it either using the scissors or you can use the energy device which you have to actually detach the appendix. This is where I had to go across to help my colleague, and there were several mistakes made in this video. Let's see if you can pick it up. Number one, the appendix has been released, and my resident has proceeded to do a lavage to clean up the area. Now, the first mistake that he has made here is the appendix is still in the abdominal cavity when he is doing the lavage, and this is against our principles of sepsis and antisepsis. All right. So many of them, when I'm not observing, they take shortcuts. They know that we are not there, but we have the video so we can have a look. So this is one such video which I feel that we can all learn from. So after this, the other thing that I find is a problem is here is when he removes the specimen, he doesn't remove it using a pouch or a bag. He removes it directly into the telescope and pulls it out. And this is again not good because it will contaminate the wound, and subsequently it may lead to infection. Of course, the argument is if you clean the wound well enough, it will not. But I think no, when you want to retrieve the specimen, whatever pouch you have, be it an endo pouch or whether you can make it on your own, it is the best for you to actually use this to deliver the appendix. All right. So let me stop sharing this and actually go back to the presentation quickly and end it. I'm just passing 12 minutes. So if you need to convert to open, you have to decide whether or not you are converting to a midline incision, a lance incision. If you cannot find the appendix laparoscopically, most likely if you do it with the lance incision, you won't be able to find it as well. So it is more cautious, it is, I think, more intelligent to convert it to a midline, a lower midline scar to look for it better. But if you have a problem, namely a bleeder, for example, from the appendicular artery, or if you're unable to get to the base when you're doing your laparoscopic dissection, then a lance incision would be sufficient. Normally, I don't leave any drains for appendix. I don't think there is any need other than the fact that if you have a very, very friable base and you transfix around the base, and then you are worried that there might be some exudative fluid, and you leave a drain just for a short time to drain that fluid while the base heals very well. So I feel that's it. I've tried my best to stick to time. Let me just stop sharing. Have I stopped sharing, Sajid?
Yeah, you have stopped already.
Okay, thank you. Thank you so much.
Okay, thank you, Ghafoor, for a nice presentation. I think it was a very good presentation for the residents, especially in terms of medical legal aspects, and also for the to take the basic measures for the removal of the the consideration of the basic steps to avoid the complication, and also to avoid injury perioperatively, and also to avoid the surgical site infections in a post-operative era. So what we used to do as well is the same principles, like if we are luxurious enough to have apply endo loop, then we will apply endo loop. Otherwise, we will go for either the Michel's knot or the other knots as well. And the endo loop, the retrieval bags, unfortunately, is not available in this part of the world where we are working in the public sector hospitals. And what we used to do is sometime they are available, but most of the time by the end of the procedure, we are using the glove finger. It's number 8 or the number 8.5 glove, the middle finger, and apply just like the sutures all around it and put it inside. So the length of the appendix is exactly like you can place it into this and then take it out. So this is just another one. So thank you, Ghafoor. We will move on to the next presentation. We are running out of the time. Mr. Tuan Lee Kwan from Vietnam for laparoscopic cholecystectomy, one of the procedure which is very, I mean, the world #1 procedure around the globe. So Tuan, hand it over to you.
Thank you very much. Good afternoon. We would like to share with you the basic technique and tips for safe laparoscopic cholecystectomy. Because we have short of time, some slide will be fast. So most of the time we do lap chole for symptomatic gallstones, although there are other indications like polyps or adenomyomatosis. The most common position to do this procedure in Asia is the main surgeon stand on the left side of the patient. Although there is alternation that the surgeons can stand beside between the legs of the patient, but we all find that the patient stand on the left side of the patient is more comfortable. This is the standard 4 trocar for lap chole, but nowadays all of our normal lap chole are using 3 trocars. It is safe and I think easy to adopt. Anyway, if there is any difficulties in exposure of the gallbladder or any adhesion, so the 4th trocar is an option. So we will go through step by step. There's many other procedures of laparoscopy. The initial trocar will be placed at the umbilicus. No matter what technique you do for the initial trocar, it is safe if you are well trained and you assess the patient right. So this is one of our technique. This is a closed technique. We lift the fascia up to make a free space behind the fascia. Use a knife to enter the umbilicus to open the fascia, and then use a trocar to enter the peritoneum space. If there is any regarding, then we should stop and do open technique. This seems to be a safe, although it is closed, because we do thousands of cases and there is almost no injury to the bowel, but you need to do it right. Then comes the insufflation. So first step, you have to expose the gallbladder and expose the hepatocystic triangle. This is important. I think the most important thing in cholecystectomy is the anatomy. So we have to remove the gallbladder and keep safe to the bile ducts. So this is the basic anatomy for cholecystectomy. That we can see the hepatocystic triangle is can be easily identified if you can identify the CBD. That means your dissection should be on the right side of the CBD and close to the gallbladder, because in the hepatocystic triangle that lies the cystic artery, and most of the extrahepatic duct variation also happens in this triangle. So we can accidentally cause damage to these small bile ducts if it happens. So this is we have to explore the anterior and posterior of the hepatocystic triangle. Another thing is important for beginner is that how you retract the infundibulum of the gallbladder. So you should pull the infundibulum downwards and laterally to open up the space, the hepatocystic triangle. This is how we find it easy to recognize the CBD. The CBD is a tubular structure that is most lateral and most superficial in the hepatoduodenal ligament. And usually we can find it in the superior body of the duodenum. When we start the procedure, we can trace along the superior body of the duodenum from lateral to medial, and easily, most of the case, we can identify the CBD. Another thing is the cause of the CBD from the superior body of the duodenum head to the liver hilum. But when you do the surgery, retraction, excessive retraction can cause a tenting of the CBD. That causes a misidentification of the CBD and the cystic duct. Nowadays, we have some new technique to identify the CBD during cholecystectomy that are the use of ICG in the new system. I think we don't have enough time to talk about that. Maybe we have to mention it later. This is the anatomy from a cadaver, and you can easily see that what I meant previously, that the CBD is the most tubular structure, most superficial and most lateral tubular structure in the duodenum ligament. Okay, let's see this patient. This is a duodenum, and from the hepatoduodenal ligament, we can see the first tubular structure. This should be the CBD rather than the cystic duct. And I think most of the case, we can easily find this structure, except that there is excessive inflammation in this area. Okay, this patient, we have acute cholecystitis, and in this case, we use ICG to identify the bile ducts. And you can see that when you use the D light, the ICG extracted into the bile ducts, you can see the blue light. So it's easy to identify that in the hepatocystic triangle, there is no bile ducts. The new system have an overlay image between D light and normal image of the laparoscope. So it's easier for us to do laparoscopic surgery with ICG. This is another case demonstrates that the most of the time the CBD is the most tubular structure on the medial side of the hepatoduodenum ligament. Another anatomy landmark should be considered is that the Ruvier Swincus. Ruvier Swincus is the place where the bile ducts and the portal vein enter the hilum of the liver. So most of the time, our dissection of the hepatocystic triangle is above that line. So especially when you dissect posterior aspect of the gallbladder, be aware of this landmark. Keep your dissection above this. So again, there are some important landmarks for you for a safe cholecystectomy. That is a CBD, the infundibulum, and the cystic duct junction, cystic lymph node, and Ruvier Swincus. So you can use energy or not, but in my opinion, as less energy is possible when dissecting in the hepatocystic triangle, and you should achieve the critical degree of safety before you transecting any tubular structure. And another interesting thing is that the cystic artery have a 1/3 of the cases have two branches, anterior and posterior branches, that you have to transect it twice in the hepatocystic triangle. And again, you have to know the normal anatomy, but also the variations of the cystic artery and the extrahepatic bile ducts. So this is a recommendation from SAGES. The safety of laparoscopic cholecystectomy requires a correct identification of the relevant anatomy. So again, I insist that lap chole is safe, that you have to master the anatomy of the region. This is how we get the critical wave safety. So we have to achieve 3 criteria that we have to clear to expose 2 windows and expose the 2 structures, the cystic duct and the cystic artery. And we should mobilize the lower third, the lower part of the infundibulum away from the liver. And 2 and only 2 structures should be entering the gallbladder before we transect any structure to prevent CBD injury. This is how we get the critical view of safety. This is anterior view and this is posterior view. Actually, if you can identify the CBD, it is much easier to do this. Somehow it takes time to remove all of the fat along this tubular structure. Or you can keep your dissection close to the gallbladder. All of the fat will be medially, keep medially. You don't have to remove all of the fat by the energy. I just show you how we do the meticulous dissection in the hepatocystic triangle. This is how we identify the anterior hepatocystic triangle. You can easily find that this is a CBD here. This is a opening of the peritoneum on the posterior hepatocystic triangle. And you can easily identify a tubular structure here. This is a cystic artery, and then comes the cystic duct. Gentle dissection along the course of the duct. And now you can easily see this is the space that we should do our dissection. Then we mobilize the lower third, lower part of the infundibulum. It can easily be done if you have, I think, a proper extraction of the gallbladder to expose the view. You can use most of the time monopolar cautery is enough. You don't have to use any other energy for this. And keep your dissection close to the wall of the gallbladder. That is a subserosal layer. You can easily find that it is safe and there is no major vessels close to the gallbladder wall. And there is always a safe plane, a vascular plane, if you keep your dissection close to the gallbladder wall. Then when we can see everything well, we do more dissection to elaborate the cystic duct. Here you can see we can expose the posterior branch of the cystic artery here, close to the liver. And if you are not have good experience, you can cause a bleeding from this artery, posterior branch of the cystic artery. So we will go faster. Then the last thing we will clip and transect the cystic duct. This is some cholangiogram, shows you the variations of the posterior ducts of the right hepatic of the right liver. And you can see as we do the cholangiogram, you can see here, this is a posterior sector of the right liver that come close to the cystic duct junction and run through the hepatocystic triangle. This is another case, and also the same variations of the bile ducts. This is also another interesting variations. This cystic duct join the posterior ducts of the right liver. And if we do not recognize this variation, we can easily cause a bile duct injury. I will show you this interesting video. This patient have impacted stones in the infundibulum. And from meticulous dissection, we can identify that it seems to be this is a cystic duct. And this is another big duct that connects the infundibulum with the right liver. And the CBD is here, is far away from this duct. So what is the variation? It's very difficult to identify. So we decide to open the infundibulum, remove the stones, remove the impacted stones, and we find there is 2 openings into the infundibulum. We do the cholangiogram, and from the cholangiogram, it is very interesting that this is the posterior right hepatic duct, and there is I think Mirizi syndrome of the cystic duct join this duct, and there is an impacted stone that causes a Mirizi syndrome to the right hepatic duct that causes obstruction and dilatation of the posterior right hepatic duct. This is a very interesting anatomy that's very difficult to recognize during our dissection. And I think it's also very rare. Okay. Then when we can easily identify the cystic artery and cystic duct, we will clip and transect the ducts and the artery. Or we sometimes, if the duct is big, we can ligate it. If there is any suspicion of bile duct stones, we can do cholangiogram or ultrasound to identify the bile duct stones. If there is a bile duct stones, transcystic approach is recommended. Otherwise, you can do the transductal, that means a choledochotomy to remove the CBD stones. Or you can do intraoperative ERCP. If there is no CBD stone, then we remove the gallbladder away from the liver. This is very simple using the hook cautery. But sometimes when we separate the gallbladder away from the liver, we can cause we can have a accessory Luska ducts directly drain from the liver into the gallbladder that need to be closed by sutures. So you should recognize the bile leak, and it's simple, just close it by sutures, put in a drain for a few days. Most of the cases it will be safe and there will be no bile leak. If there is, most of the time it is self-limited and mild bile leak. Okay, in most of the time, drain is not recommended for cholecystectomy, except there is a severe inflammation in cholecystitis. The gallbladder usually removes via the umbilical port. And another thing is that whenever there is a very difficult cholecystectomy, we should know about bailout procedures. That means this is a subtotal cholecystectomy. We can let the infundibulum open, or we can close it. most of the time, we cannot close the infundibulum. This is how we remove the gallbladder without identifying the cystic duct. We can close the infundibulum or let it open. And in this series, we find that subtotal cholecystectomy is a very good option for us to keep things safe. In up to 1/3 of the cases, we have to do ERCP, and only 6% need the second procedure to remove the remnant of the gallbladder. And this is, I think, a safe bailout procedure that we have to know when we start to do laparoscopic cholecystectomy. Just another video and I will finish. In this case, the wall of the gallbladder has been severely necrotized. It is impossible to identify the wall of the gallbladder. And after remove the distal part of the gallbladder from the infundibulum, we can easily find out that this is the mucosa of the infundibulum and the opening of the cystic duct. Just a gentle closure. Try to close the opening of the cystic duct, but you don't have to make it deep because you can cause a bile duct injury. Just to keep the tissue closed. You can see still have a bile leak, but then we can put in a drain, and bile leak usually self-limited and will be stopped after 7 days to 10 days. This is some guidelines that we should follow during our dissection. We should use as less diathermy as possible. We should mark the Ruby sulcus to keep our dissection safe, and we should avoid dissection on the left side of the hepatoduodenum ligament. And it is very important that we should develop a culture of safety when performing lap chole. Although some cases are very easy, but we have to know that variations of the anatomy, variations of the artery can cause problems. And this is from SAGES, a program that they try to adopt a universal culture of safety in cholecystectomy. We have to use a critical way of safety. We have to have some time for time out before cutting any tubular structures. And we should get help from another experienced surgeon whenever we got in trouble. For conclusion, for safe cholecystectomy, we should learn about the normal and aberrant anatomy of the region. We should have a good attitude for safe cholecystectomy, and we should know about the bailout procedures in case of difficult cholecystectomy. Thank you very much for your attention.
Thank you, Tuan. Thank you for a wonderful presentation and showing various videos, including the complications as well as the variant anatomy as well, and how to deal with the variation in the anatomy, and using the technology as well to avoid these complications to do a safe laparoscopic cholecystectomy. I think we move on to the next speaker, and it's apparently myself. So so I will move on to the, I will start sharing my slides, and then we will end up with our last presentation and the chairman of this session, co-chairman of this session, Dr. Sujit. So let me share my slides. Okay, so I'm going to talk about the laparoscopic total extraperitoneal repair for, sorry, just give me, there is some, yeah, okay. So, yeah, so laparoscopic total extraperitoneal repair for inguinal hernia repair. And I would like to acknowledge Professor David Lumanto and Dr. Sajid, who trained me enough to do laparoscopic inguinal hernias independently, and helped me a lot during my fellowship in minimally invasive surgery while during my stay in Singapore. Well, this is a very famous quote about the hernia repair by Mr. Cooper, 1804. The surgeon, no disease of the hernia body, the human body belonging to the province of the surgeon requires in its treatment a better combination of accurate anatomical knowledge with surgical skills than the hernia itself in all its variants. So the basic theme is the inguinal hernia. It's not about the surgery. It's basically about the inguinal anatomy. If you going into the right planes, the hernia surgery would be fantastic. But if you just leave one place above, or if you go one place one space above or below, it could be a complete disaster, because the space is very short and it's a limited area, and you have to be very accurate and meticulous in your dissection. You must keep in your mind where exactly is the disastrous areas, like inferior epigastric vessel, where is the vas deferens, testicular vessels, median and the medial umbilical ligaments. Everything you have to keep in your mind. And after the dissection, every aspect of the inguinal area, the pelvic anatomy, should be clear in front of you, like the dangerous triangle, like the pain triangle, as well as the Hasselbeck triangle. So why is that important? Not only to complete the hernia dissection, but the main aim should be for the prevention of the recurrence as well. For a laparoscopic TE repair, the patient preparation and the selection of the patient is very important. I won't go into the details of the patient selections. I will just jump into the basic steps of doing a laparoscopic TEP repair. Actually, no NGT is required for the inguinal hernia repair if you are doing this procedure. And no Foley's catheterization is also required, because I have seen a lot of surgeons around, and I have met them, that they used to place Foley's catheter. Patient just has to go to the washroom to empty the bladder before entering into the operating room, and that would be more than enough. Yes, Foley's catheter sometimes is required when if you are dealing with difficult hernia, like if there is any previous inguinal area surgery like prostatectomy, or it's a recurrent hernia, or dealing with a bilateral recurrent hernias. If you're suspecting something like this, then better to go with the Foley's catheter. And the patient position should be 15-degree Trendelenburg position, like a flex table. Initial incision is very important. You give a transverse incision on the anterior rectus sheath, and you retract the external oblique muscle towards, rectus abdominis muscle laterally to go into the preperitoneal space. And here you can have a look. After placement of the Hassan's trocar, you place your two ports in the midline for TEP repair, 3 finger breadth above the pubic tubercle, the pubic bone, and then another one halfway between the pubic and the third one. Let me show you a video here. So you have to stay between the superficial and the deep layer of the fascia transversalis. If you go above and below it, there is a that would be a vascular plane, and that would lead to a complete, the vascular injuries, and it would be all red, and you won't be able to see anything. So you end up here, you can have a beautiful view of this pubic bone. So you are in the midline, and then you can place both of your trocar in the midline. Staying 3 fingers above the pubic tubercle, and the second one, it should be in between these two, like this. And if I can show you the first one, and then we will go for the second one like this. Your hand movement should be very, very meticulous. If you go like if you apply a lot of pressure, then you can end up into creating a pneumoperitoneum, and which would make it very difficult to perform the surgery. And it's always better to use a blunt dissector instead of any Maryland and or any other device. And the movement of your hand should be like controlled, not like swimming, like my professor used to say. And this fat should always go up. Then you will be like in your right plane. Why not balloon dissection? Most of the people favors the balloon dissection, but personally we won't, because of the higher cost, a longer operative time, asymmetric dissection. We are not sure either you are in a right plane or in a wrong plane, and if you are unfortunately in a wrong plane, it would be more traumatic with the risk of vascular injury as well. So the careful initial dissection is very important, because when you are dissecting here, you have to identify all the structures. Apart from the inguinal hernia, there is a chance the patient may have a combination of hernias. Like if the inguinal wall is weak, the possibility of like if you can see here, there was an sorry, this one. So if you can see here, there is a small component of the femoral hernia, and this one is here you can see the obturator hernia as well. So you can easily miss the findings as well, and these things can go unreported, that there was only the femoral hernia, the inguinal hernia. It's actually a female patient, who was having this combination of hernia. So initial dissection is very important, and never go to identify the nerve. Here you can have a nerve. Don't go to look for nerve by yourself where exactly is this the nerve is, because if you will try to locate the nerve, definitely you are going to injure this one. But if you are doing your dissection in a right plane, then believe me, your nerve will come into your pathway, but you just need to identify that nerve. Let me go to the next one. And initially, it could be difficult, but remember the basic principle. Here you can have a look that there is a lot of fat, there is a lot of, the patient is obese. It would be difficult for you to go into a right plane. So what you need to do is to stuck with one principle, that this fat should always go up, then you can enter into a right space. And then identify the planes, and then how to deal with the sac. Okay, so the basic principle here is, when you are dealing with the sac, always try to stay closer to the deep ring. If you will try to stay away from the deep ring, the chances of injuries are higher. So try to stay closer to the deep rings to avoid injury to the vas as well as the vascular structures. And then this peritoneal lateralization of the structures and the peritoneum until you dissect the preperitoneal space with the retroperitoneal space. Your dissection should be so meticulous that your mesh your dissection should aim that you are not placing this mesh just for the safety of this foramina, but not for the defect only, not for the hernia, but you have to avoid the recurrence, which I have told you in the start. Here you can have a look again. And then again, there is a chance that you may come across with a pseudo sac like this one. So what you need to do is, again, stay closer and then hold while staying closer to the deep ring, and hold with one hand and try to remove it with the other. Complete it reducily, and then here you can go. And then, yeah. Okay. So be careful in your dissection to avoid injury to the other structures. There is another difficult case of inguinal hernia. So that could be done as well. This surgery was done by Professor David Lumanto. And I was the assistant. And how to reduce this one is you can open the sac always and reduce the content into the periperitoneal space and then put it back into the peritoneal cavity. And then dissect the sac, complete your dissection, identify the structures around the sac, identify the vas deferens and the vessels before ligating the sac or before ligating or doing incision over the sac. Once the structure are identified, the vas deferens and the vessels, go for dissection, complete your, and then you can end up with the closure. The closure can be done in various ways. Either you can close it with using hemolog, or you can actually use a V-lock suture, or you can repair this one. And always remember one other thing, as I've told you in the start, it's not about the hernia repair. It's about the prevention of the recurrence, as well as avoidance of the various structures who are present in this area. Avoid corona mortis, because when you are dealing with the dissection, especially with the femoral hernias as well as the obturator hernia, it could come into your way. Avoid triangle of the pain. Selection of the mesh. This is very important. What I used to do is, before my this fellowship in hernia surgery, the placement of the mesh should be like 6x11 or a smaller size mesh, and cutting the mesh according to the size of the defect. But that was actually a wrong practice. The size of the mesh should be minimum 10x15 centimeter for both TEP and the TAPP repair, irrespective of the procedure. This is the minimum standard size. And if the defect size is more than 3 centimeter, I would recommend to consider closure of the defect, followed with the deployment of the larger mesh of 12x17 centimeter, like this. If I can show you, yeah. So, or you can use an anatomical mesh which is a 3D anatomical mesh if you have a luxury to using this mesh like this, and 3-point fixation at the Cooper ligament above it, and one at the top and laterally, and then on the other side. And this is again that was an anatomical mesh, but this is the 10x15 mesh. And remember one point again, for the prevention of the recurrence, apart from the dissection, you have to do one thing. Your dissection should be from a midline to the laterally, and the lateral endpoint should be until the iliopsoas muscle. Until you reach the iliopsoas muscle, then it means you are in a right dissection plane, and you have created a right place. And the lateral corner, the lower edge, should go into that space here. And then on the midline, both of the meshes, if you are doing a bilateral inguinal hernia repair, should be fixed accordingly, like they should be covering each other. And on the top of the mesh, and the top of the mesh should be like because the midline port, the suprapubic port, was a 3-finger below the 3-finger above the pubic bone. So the upper margin of the mesh should be along with the port. Then it means you are deploying your mesh in a right plane. If your mesh is like angulated, or if you are, it may be a too higher, or it may be a too low. And the last step, in the end, which I've learned is to hold the mesh before removal of the scope out of this preperitoneal cavity, because that would lead the mesh rolling. And in the end, I would like to say that I know more than 100 surgeons. This is Mr. Ogilvy, who famous for Ogilvy syndrome, who said, I know more than 100 surgeons whom I would cheerfully allow to remove my gallbladder, but only one to whom I should like to expose my inguinal canal. Thank you so much. And the take-home message for this presentation would be, generous dissection of the Bogerus and the Retzia space, complete peritalization of the cord structures. As I've told you, placement of the larger mesh. Don't go for a mesh of your convenience. Go for the mesh of the patient's convenience. You have to dissect at the right plane for the right mesh. And minimal fixation unless required, which may lead to the post-operative pain and a lot of things. Thank you so much.
Thank you, Sajid. Okay, so I'll share my screen.
So the next presentation would be by Dr. Sujit, co-chair of this session for today. Yeah.
Thank
Dr.
you, Sajid, for
please.
sharing. Sorry, I was operating before. Yeah, can you all hear me?
Yes, can hear you and can see your screen.
Can see my screen? Huh?
Yeah.
Okay. Okay, so there's many ways that you can do ventral or incisional hernia. There's plenty actually. So nowadays there's all sorts of things are being discussed. But the traditional Mayo repair is not really advised now. If anything more than 1 centimeter defect, it's best that you put a mesh, not just a suture repair. If you do an open repair, there's inlay. I won't go into too much detail. I will explain when it comes to the video. Then for laparoscopic, there's an IPOM that most of us are familiar with. Then there's Milos, there's Emilos, there's tape, then there's PPOM, and so on. So I will discuss some of these things, whatever things are relevant for a beginner. Then I will move on to a little bit more complex things. Okay. So moving on. So this is a patient with a 2 centimeter defect. This patient has a paraumbilical hernia. So the current guideline basically supports this particular repair for up to 4 cm. You can do this kind of a repair. So, and there are new measures available. For an example, one is a ventral patch. The other one is ventral legs. So this is a ventral patch mesh. So this is a absorbable hard skeleton that will reduce the amount of mesh overlap you need. So you dissect the hernia sac and then bring the hernia sac down. So enter the peritoneum and then make sure no additions around it. And then we suture the mesh to the fascial edges. We use non-absorbable Prolene sutures and then repair the fascial defect over the mesh. Yeah. So quite a easy repair, this one. And then after the fascia is closed, we can actually reconstruct the umbilicus quite nicely. Yeah. Then we close in layers. So this is immediate post-op. Yeah. So the cosmetic effects of this particular repair looks quite promising compared to what we do with laparoscopic repair. So anything less than 4 cm, this method can be used. Some important aspects to discuss in terms of incisional hernia repair. So this is a big incisional hernia with additions to bowel. So if possible at all times, use sharp dissection. So you know what you are injuring, and if you injure, the injury is specific to that particular site. And if you use energy device, the issue is there's lateral thermal spread. So what you see may not be the actual injury. So if possible, when bowel is stuck to the abdominal wall, it's important that you use a sharp dissection. And it's important that you leave peritoneum on bowel and not bowel on peritoneum. Yeah. So when you're quite clear that bowel is not involved, then you can use energy device, or if you're quite far away from bowel for amytal additions, etc., you can actually use the energy device, reduces the bleeding and makes the operation faster. So some of these videos are actually by Prof. Lamanto as well, when I was training under him. So you can see, so these are some of the challenging cases. So multiple defects, what to do with this kind of case. So it's very important. The basics are quite simple. First, handle the neck of the hernia. If the neck of the hernia is too narrow, to reduce the contents, make the hernia neck bigger. And then safely bring down the additions and bring down the contents under vision. Always inspect the contents and then make sure you tackle all the hernia defects properly before you move on to any form of repair. Nowadays, the current guidelines actually suggest us to close the defects as possible. So closing the defects can be done with intracorporeal suturing, or you can use extracorporeal sutures to help your intracorporeal approximation of the defects. You can see the old suture repair here. The old sutures are there. Okay, I think I will fast forward a bit here. So it's very important when bowel comes into your vision, it's very important that you keep the bowel under vision and then stay away from the bowel. You can always take a bit more of the fascia or the peritoneum, but make sure you don't take bowel instead of the fascia. So always fascia or peritoneum on bowel is definitely healthier than bowel on peritoneum, which means we are in trouble. Sometimes there can be bowel injury. So if it is a contained injury, do a repair on site, okay? And if it is not extensive contamination, you can still go ahead with a mesh repair. But if there's extensive contamination, say like colon perforation, then best is to do the mesh repair at a later date and let the patient recover, do the definitive repair for the hernia, and then come back on a later date. Put some anti-adhesive films over the dissection sites, and then come back maybe about 4 weeks later to do the repair. So different type of energy sources are used here to do the dissection. You can see a number of defects in the fascia. So we close the fascia, then we use a composite mesh for this kind of case. In the current guidelines, absorbable tech versus non-absorbable tags has been discussed as well. So in complex hernia with large defects, actually can use non-absorbable tags, and there's not much of a difference. One more case. This is a patient who had a phalansteal scar and ended up with an incisional hernia. So what you saw before was IPOM repair, and what you're going to see here is a transabdominal partially extraperitoneal repair. So to do a TAPE near, these are challenging cases near the symphysis pubis. There's not much space to anchor the mesh. So in this kind of scenario, best is that you expose the Cooper's ligament on both sides, bring down the peritoneum, clear the peritoneal flap, and then repair the defects, and then do the mesh placement and anchor the mesh to the pubic tubercle, the Cooper's ligament, and then close the peritoneal flap over the mesh. So I'm basically bringing the peritoneum down and creating a space to the mesh. I'll fast forward here. So dissection is done. So this is how we close the defects. So I use extra peritoneum because the number of holes were quite big. Then I use non-absorbable barb sutures to deal with the rest of the defects. So a couple of transfascial sutures using the suture passer. Then reinforce the repair with some barb sutures, non-absorbable barb sutures. Okay, then the mesh. We use a composite mesh because part of the mesh is actually exposed into the peritoneal cavity. But we anchor the mesh into the Cooper's ligament on either side. I use absorber tackers here. Then we close the peritoneum over the mesh after that. So it's important that you catheterize these patients if you're doing a TAPE because operation can take long and you need the bladder to be decompressed. Then there you go, the peritoneal flap is being closed over the mesh. Yeah. Okay. This is another difficult hernia. This is a incisional hernia. It's a lateral abdominal wall hernia after a lens incision. So in this particular case, the bowel additions were quite difficult to bring down. So this is where hybrid techniques can help. So you can actually open up the hernia sac anteriorly and then bring down the addition safely under vision. And then close the defect and then go back into the peritoneal cavity and put a mesh. So it's more ergonomic and it's safe. So I'm using sharp dissection because I'm very close to bowel. So unlike energy devices here. So this the bowel is going in between the muscle layers. The patient also had a direct inguinal hernia there. So it was a bit difficult to bring down the addition. So without wasting more time, what I did was I just opened up the hernia sac and then bring the additions down and then did the fascia closure, then put the mesh back. So mylos and amylos also have similar concepts that you can go into the hernia cavity and using the endolaparoscope and then use additional lysis and then do a repair using endolaparoscopic approach within the hernia cavity. So again, a composite mesh because the mesh is exposed in the peritoneal cavity. And the lower edge you can't anchor anywhere. So this particular case, the lower edge of the mesh needed to be sutured to the peritoneum. Okay, I think that's about it. So a summary, what to do for, if it's a less than 4 centimeter defect, an open mesh repair with one of the new meshes can be done with a hard skeleton that is absorbable after about 1 year. That provides enough time for the hernia to heal properly. Less than 5 centimeters or more than 5 centimeters can use laparoscopic repair. For primary repair with just diastasis of recti, can use either laparoscopic rectus diastasis approximation technique or with robotic repair. Without diastasis of recti, can use our standard IPOM plus. IPOM plus means with the closure of the defect. Incisional hernia can be a bit tricky. Beyond 15 centimeters, we should do open repair. Shouldn't be doing laparoscopic repair because physically it's not possible to close most of these big defects. What's in between is 5 to 15 centimeters. We can do a laparoscopic IPOM plus repair, but depending on the defect size as well as the patient's BMI, the patient needs to be optimized. So weight needs to be reduced using that optimization, and then can use other adjuncts like basically in our center we use so we don't use much component separation. So but what we use in our center is mainly Botox injection, which is a well-known technique, and it basically helps with the defect closure and to repair the hernia successfully. I think that's all I have. Happy to answer any questions. Thank you. I'll stop sharing my screen.
Yeah, thank you. Thank you, Dr. Sujit. So this is all about for today's presentation. Before moving on to the polls and to the MCQs,